Hey YouTube, what's up? This is Dr. Alvaro, your favorite virtual cardiologist and nutrition expert. If you want to know a little bit more about me, you can look at the introductory video. If you want to see my credentials, you can look in the description below. For now, let's just get right to it. Topic number one is chest pain. And I chose this topic because I have no subscribers yet, but eventually I would like the topics to be chosen by you guys. So leave me in the comments section anything you would like me to talk about related to cardiology or nutrition or whatever else. So let's get right to it. Chest pain. Why did I choose this? Very common topic for heart doctors. Patients come in to the office all the time asking about chest pain, obviously to a heart doctor. Also, I get questions from friends and family members and acquaintances and people randomly meet in the street who find out I'm a cardiologist, want to know about their chest pain. So let's talk about chest pain. As it turns out, there's quite a bit of misconceptions out there, and I took to the streets for a little bit to uncover some of these. Which one of the following two is worse, if you have 3 minutes of pain or 3 days of pain? So I'm just going to give you a little quick story about Bill and Jill, and then you tell me which one is more likely to have a blockage in a heart artery responsible for their symptoms. Which quality of pain is worse, if it's a stabbing pain or if it's a vague pressure? And now you got to choose Bill or Jill.
And I thought I would know all of them because I've been through it all.
And that's Bill and that's Joe?
Bill and Jill.
Okay.
Bill is a 45-year-old male smoker. He's had 3 days of left-sided sharp stabbing pain that's clearly worse when he takes a big breath. Is it worse if your discomfort that you're having changes or gets worse when you take a deep breath, or if it doesn't change when you take a deep breath?
It gets worse when you take a deep breath.
Jill is a 50-year-old diabetic woman. She had 3 minutes of chest discomfort right in the middle of her chest, described as a dull ache. It didn't change at all when she took a big breath. Which one is more likely to have a 75% blockage in a heart artery responsible for this symptom complex that each one has?
I'm going to go with Bill.
My first thought's Bill.
You're saying Jill?
Okay, I would say.
You're saying Bill? So we got Jill, Bill, Jill?
Just with the dull and the sharp pain, I'm going to have to go with the dull pain.
Yes! What's up, bro? Nice!
I was actually on Stanford's campus for some of those questions, surrounded by very smart people, and the misconceptions are still there. So let's talk about some basics about chest pain to clear up some things, and so you can understand how heart doctors think about it. What a heart doctor thinks about chest pain is all about risk stratification. In other words, what are the odds that your chest pain is something very, very worrisome? What are the worrisome causes of chest pain? A blockage in a heart artery, a blood clot in the lungs, a torn aorta. What are the less worrisome causes of chest pain? They are in the list of what we call non-cardiac chest pain, and that's basically divided into 4 categories. GI, or anything in the gastrointestinal tract that can cause discomfort: esophagus, stomach, gallbladder. That's number 1. Number 2 is musculoskeletal, joints, bones, tendons, ligaments, cartilage. You have all that stuff here in your chest wall, and any of it can get inflamed or irritated and hurt. Number 3 is pulmonary, lungs. You could have bronchitis or pneumonia or pleurisy. Any of those things could cause chest discomfort as well. And last but not least is anxiety, which is a very common cause of chest discomfort. So what we're trying to do is figure out what are the chances that your chest discomfort represents something that we really need to worry about. And so we tend to place people into high and medium and low risk categories. And believe it or not, there's actually a score out there called the heart score that's used in emergency departments. And the heart is an acronym. So the heart score rather is an acronym. H stands for history, and E stands for EKG, and A stands for age, R is for risk factors, and T is for troponin. Now, 3 of those we can use just our words to figure out. 2 of those are actual tests, and that's the EKG, which is the 12-lead EKG that you look at the squiggles on, and the troponin, which is a blood test to see if you've done heart muscle damage. I can't do either of those to you because this is virtual cardiology. Nevertheless, a very, very important component to this heart score is those other ones: the history, the age, and the risk factors. Now, with this heart score, each category gives you a certain number of points, and at the end you add it all up and you put that into a profile which puts you in a risk category. So let's talk about how the points are distributed for the three variables that we can talk about. Number one is age, and the cutoffs are actually 65 and 45. So if you're 65 or older, that gives you 2 points in the scoring system. If you're under 45, that gives you 0 points. If you're in between, that gives you 1 point. So you can see age plays a very important part in risk stratification for whether or not your chest pain might represent something worrisome. Okay, the next letter we're going to talk about is R, which stands for risk factors, and I'm going to list those up here. As it turns out, if you have none of them, you get a score of 0. If you have 3 or more of them, you get a score of 2, and if you only have 1 or 2 of them, you get a score of 1 in the heart score. Okay, so what are these actual risk factors? I'm going to list them for you up here. Number 1 is if you have a history of high blood pressure or hypertension. Number 2 is high cholesterol. 3 is diabetes. 4 is smoking. 5 is obesity if your body mass index is over 30. 6 is if you have a family history of cardiovascular disease, and that means a first-degree relative, a parent or sibling, who was diagnosed with a blockage in a heart artery under the age of 65. And last but not least is if you have a history of atherosclerotic disease. In other words, if you have a history of blockages in the arteries in your body, in your heart, in your brain, in your legs. Have you had a heart attack or a stroke? So you look at all those together and you decide how many of those do you have. And again, if you have 0, that gives you a score of 0. If you have 1 or 2, it gives you a score of 1. If you have 3 or more, that gives you a score of 2. So that is the age and the risk factor part of the heart score. Okay, the last part we're going to talk about is the history, and this is where the art of medicine comes in more than anything else, because the history has to be elicited by the heart doctor. We have to talk to the patient, and based on what the patient tells us, make a decision on whether we think that this history is highly, moderately, or only slightly suspicious. And those are actually the 3 categories in the heart score. You get 2 points for highly suspicious, 1 point for moderately suspicious, and 0 points for slightly suspicious. So what is it about the history that makes us highly or moderately or slightly suspicious? And basically these are qualitative and quantitative components to the discomfort that you have. And we have to ask a bunch of questions to try to figure this out. So the questions that we ask, I'm just going to go through them with you and then explain a little bit about each one. So the first thing I would ask my patient is, how long have you been having this pain for? And if the pain has been going on and off for 10 years, that's very different than if they've been having it only for the last week or so and it's been getting worse and worse with exertion or with less and less exertion. Because if you've been having the same pain for 10 years, it's probably not your heart, or at least it's not going to kill you because it's been going on for 10 years. On the other hand, if it's been getting worse and worse for the last week, that's a little more worrisome. How long does each episode last when you do have it? If each episode lasts for 1.5 seconds and it's a sharp and stabbing quick zinger like that, that's almost never the heart. The heart pain from a blockage in a heart artery almost always lasts at least a few minutes. Also, heart pain doesn't tend to last for days and days on end. If somebody says, I've had the exact same pain for 3 days, that's not likely from a blockage in a heart artery either. Again, heart artery pain is typically with exertion, or if it's going to be at rest, it's a few minutes. Now, if you're having a huge heart attack, it could last longer, but again, not for days. So that's the second question that I ask. The third question would be, when you're having the pain, does it go anywhere? Does it go into your jaw or neck or tooth or shoulder or arm? Because heart pain oftentimes radiates to one of those places. Not always, and other pain can radiate there as well, but that's something that's important. Next, I ask, do you have any associated symptoms? When you're having the discomfort, do you get nauseated? Do you get profoundly sweaty? Do you become short of breath? Do you get lightheaded or dizzy or pass out? So if you have nausea and sweatiness and shortness of breath with your discomfort, that is more worrisome than if you don't. The next thing that is very important to ask is, while you are having the discomfort, does it change if you take a big breath or move a certain way? In other words, does taking a big breath like that make it worse? Or if every time you put your arm behind your head or roll over a certain way, does that make it worse? Or is it worse if you push on a certain spot? because pain from a blockage in a heart artery does not change when you take a big breath or when you roll over a certain way or when you push on it. In fact, there are some heart scores that actually detract points if your discomfort changes with deep inspiration or movement or with pushing on it. Another very important qualitative component when asking a patient about chest pain is to describe what it feels like. Sharp and stabbing pains tend not to be from a blockage in a heart artery, whereas somebody that describes a pressure or a band-like sensation around their chest or a chest heaviness is much more likely to be pain. Again, people use different words to describe the same thing oftentimes, but that is a piece of the history that's very important in trying to find out whether this discomfort is real with respect to a blockage in a heart artery, or could it be something else? So again, sharp and stabbing is typically much less likely to be from a blockage in a heart artery than a pressure or an ache or a toothache in my chest or a band-like sensation or it feels like something sitting on my chest. That's much more worrisome. Another critical piece of information to ask is about the timing of the discomfort. If the discomfort happens any time with no particular relation to any activity is very different than if the discomfort happens reproducibly with exertion, because that is much more likely to represent a blockage in a heart artery. Especially worrisome if less and less exertion is causing similar discomfort, suggesting the blockage might be getting worse or is an unstable plaque. So if a patient says, every time I climb steps or go up my driveway I get chest discomfort, is very different than if they say, yeah, I don't have any problem exercising, but I often have the chest discomfort when I watch TV, and then might happen when I exercise, then sometimes it happens when I roll over. So it's random times of discomfort is very different than reproducible exertional discomfort. Again, even more worrisome if it's with less and less exertion. The next question that I ask is, what relieves the pain? Do you get relief from taking Tums? Do you get relief from taking nitroglycerin that somehow you had? Do you get relief from resting? Do you get relief from drinking Pepto-Bismol? What is it that relieves your discomfort? And again, if your discomfort is relieved by taking Tums or drinking a glass of water, that's not likely heart related. Also, it's important to know what is the severity of the pain. On a scale of 0 to 10, is it 10 out of 10? Is it 1 out of 10? Because that influences the way we think as well. So those are the non-test components of the heart score: the history, the age, and the risk factors. Again, the EKG and the troponin we can't do, but the other ones are very important, especially in the office setting, in the outpatient setting, for understanding what a heart doctor thinks about a patient. Now, what do we do about this? What do we do if it turns out that we think that after getting all this information, we think that it's a very risky situation versus a medium risk situation versus a very low risk situation? If it's very high risk and we're very worried, we might go ahead and put somebody in the hospital for observation and possibly even invasive testing like a heart catheterization, where we go through your wrist or your groin and insert catheters into your heart arteries and see if you have blockages. On the other hand, if you're super low risk and we're not that worried about it, we might say, well, let's not do any fancy expensive tests for now. Why don't you just try some Advil or some rest, or just let me know over the next few weeks how things are going on. Come back in 2 or 4 weeks and tell me if you're still having this weird discomfort, and then we'll make some more decisions then. So on a low risk patient, we might be apt to just do nothing, or again, try Tums or Advil or something like that and see if that makes them feel any better. And then there's the intermediate risk, which is, well, we don't want to put you in a hospital, but we don't want to do nothing either. Why don't we do a stress test and maybe an ultrasound of your heart called an echocardiogram, or even a Holter monitor, which is a monitor of your heart rhythm or something like that. Just some non-invasive testing to get a little bit more information. So all of this information that I'm giving you, by the way, is not a substitute for talking to your doctor. It's just information that I actually enjoy conveying because it's in my head and I got to get it out and I want the world to know. I get asked this stuff all the time, and now I have a venue by which to regurgitate it back to you. So I hope that you enjoyed it. I hope this helps you a little bit. Again, feel free to leave me comments or questions in the comments, as well as topics that you want for future discussions. Thank you so much for tuning in. Don't forget, if you watched and you enjoyed it and you want more of this, please hit the like and the subscribe. I will see you guys later. I gotta go feed my cats and go mountain biking, because that's what I do as a retired interventional cardiologist. Y'all have a great day, and I'll see you soon.